I'm going to share with you the technique of quick chop, in this case of posterior subcapsular cataract, using high magnification as I always recommend, starting with the capsular axis, following the rules to make a continuous circle capsular axis about 5 to 5.5 millimeters in diameter. This is followed by hydrosection. We decompress the eye to get some of the viscoelastic out. Then injecting with the 27 gauge cannula into the equator of the lens and making sure that the wave of hydrosection passes to the opposite side. Once you see the wave passing the opposite side, then you are sure that you made a good hydrosection and you don't need to inject more or even to check the rotation of the nucleus. This is followed by introduction of the phacotip and the Neumann nucleus splitter or chopper. Here the phacotip engages the nucleus and we split the nucleus along the cleavage lines, and as you can see it splits easily. You don't have to pass it 180 degrees, and then you start to crack part by part using the vertical chopping technique, which allows you to work in the center under vision, and this is useful technique in any type of nucleus or any type of size of a pupil. Please observe the use of high vacuum and minimal or no ultrasound. The main player here is the vacuum, and the ultrasound just helps to aspirate a clogged tip. See, engaging, occluding, then helping with the other head to slice this piece of nucleus into smaller and smaller pieces that can be easily aspirated. And as you can see, using high magnification allows you to see very well how the nucleus fragments behave, how the tip behaves, how the capsule behaves, so you can understand exactly the phacodynamics and the mechanics of what's going on in the capsular bag. Always work in the capsular bag. This makes it very safe to the corneal endothelium and improves your postoperative visual results and saves the cornea a lot of insult. Vacuum, essentially vacuum. The chopper just helps to slice and feed into the phacotip. Ultrasound is minimally needed. Dealing with the last part of the nucleus and epinucleus, and if you do good hydrosection, usually the epinucleus comes out with the nucleus, and even irrigation aspiration is a much simpler step. Once you go out, don't leave the chamber collapsed. Inject viscoelastic to have a full pressure in the eye until you exchange the handpiece with the irrigation aspiration cannulas. I use a bimanual irrigation aspiration, which is facilitates aspirating the cortex in any part of the capsular bag. The irrigation cannula usually is pointing toward the capsular bag, so as it inflates the bag always and facilitates the aspiration of the cortex. Once you are not able to remove part of the cortex, you simply go out and exchange hands to reach the once was unreachable cortex. Now, after you remove all the cortex, there is always cells overlying the posterior capsule that you can easily wash with jets of fluid using the 27 gauge cannula. So as you are able to clean the posterior capsule. Here you can see a sticking fibrous crescent on the posterior capsule. But with this magnification, you can easily see the cleavage plane between this membrane and the posterior capsule, so you can remove it safely under vision. Once you have done this, inflate the capsular bag with viscoelastic and the anterior chamber and get ready to implant the lens. Here the incision is enlarged because this hydrophilic lens needs to go through a 2.4 incision, and the cannula is inserted to help counter pressure during inserting or injection of the lens, and at the same time it will act to push the lens into the capsular bag while it's unfolding, making the unfolding into the capsular bag a straightforward step. This is followed by irrigation aspiration of the viscoelastic from in front and behind the intraocular lens to avoid unnecessary increase in intraocular pressure postoperative. Once you have removed enough of the viscoelastic, you hydrate the wounds, both the paracentesis and the main wound, and then inject an antibiotic into the capsular bag and the anterior chamber to avoid incidence of endophthalmitis. Thank you.